Thank you very much to the organizers for the invitation to speak today on the physiology and clinical utility of AMH in follicular recruitment and growth. Disclosure, received royalties from a licensing agreement between Rutgers Medical School, MGH, and Beckman Coulter for the use of AMH in determining ovarian reserve. Okay, the relevance of AMH in reproductive biology and medicine. Some of these topics I'm going to review in the next 25 minutes, some I won't. In utero fetal sexual differentiation, everyone's familiar with. Regulation of normal follicular development and abnormal follicular genesis. We'll review that this morning. Regulation of atresia and apoptosis. No. Real-time biomarker of ovarian age and egg supply. Yeah. Prediction of a woman's reproductive lifespan and the prediction of menopause. Yes. Individualization of ART stimulation protocols and dosing. Individualization of fertility preservation, counseling and strategies. Yes. Granulosa cell tumors. No. Diagnosis of PCOS. Yes. Providing insight into how genetics and environment may impact an ovarian aging. No. And potential therapeutic AMH analogs to be developed. Yes. And Dr. Sen will follow up on a lot of that. So I'm going to review the biological basis of using AMH for ovarian reserve testing, discuss the potential roles of AMH in reproductive medicine, diagnostic, therapeutic, possibly pharmacologic. Everyone's familiar with this and the milestones of the development of diminished fertility over time. And in the 80s and the 90s is basically the way we looked at the stages of follicular genesis. And at this conference, we've heard some fabulous talks about the details of the genes and the paracrine factors, so that if we look at this in terms of gonadotropin dependent paracrine control, and we see that AMH is relatively early. Dr. Gleicher yesterday was talking about improving outcomes of oocyte and quality, and other speakers were speaking about improving the quality of embryos based on the oocyte. And so a lot of these biomarkers, which we started in FSH in the late 80s, inhibin in the early 90s, and AMH in 2002, 2003, we keep going more and more toward the primordial pool. And many of these are basically indirect markers. If we split follicular genesis into early and late, and we look at the preantral stage, we understand the follicle is basically an AMH secreting paracrine signaling unit and an indirect proxy for the primordial pool. And the feedback loops that we're used to in late follicular genesis don't appear to be present. The duration is in terms of months. We know it to go from a primordial follicle to a preovulatory follicle. That can be up to a year. And once gonadotropin receptor expression is developed and responsiveness is developed, we have the antral stage follicle. The follicle becomes an endocrine secreting unit, and we have negative feedback loops, which lead to greater variability, and that duration of time is much more finite, measured in terms of weeks. So we know AMH is inhibitor has a negative influence, if you will, between the primordial follicle and the small preantral follicle. So it affects recruitment at that site and selection by inhibiting the effects of FSH between the antral and the larger antral follicles. So when we go back and look at the number of follicles that decrease over time. And we look at AMH, we see it follows a similar pattern in the same at the same time, and basically has some variation, but compared to other analytes, a minimal variation between the cycle, within a cycle, as compared to the classic hormones that we're familiar with, and some that are a little more recent, such as inhibin. So the consensus regarding AMH over time is that it's probably the earliest and most sensitive serum marker of decreasing egg supply to date. It has the least intercycle variability, and we have used it liberally, measuring it any time during the cycle. There have been many studies that have shown some variation, but at this point, I would say that it seems to be random. Others unique usefulness of this has to do with age-specific values, as you'll see, and you may or may not be using it in that regard in your practice now. So in terms of assessing ovarian reserve, we know it predicts egg number, ovarian response, cancellation, and the incidence of ovarian hyperstimulation. So it impacts, as clinicians, it affects the type of treatment that we use, the protocols that we might use, how we can avoid OHSS, and give realistic expectations to couples who are cycling. It also gives us an idea of who may or may not be an excellent candidate for egg donation, and pre-chemo for cancer treatment, helpful in terms of what we may or may not expect pre and post chemo, predicting the onset of menopause, and helping us in the diagnosis of PCOS. In terms of the lines of evidence that support it, we know it correlates with the primordial pool, the number of units. It's inversely related to chronological age, predicts ovarian reserve and ART, and the timing of menopause. FSH compared to AMH, we're all familiar with that. Probably the great advantage that FSH has at this particular point is how quickly you can get the result. It's automated. You'll do it in your office. You get it within an hour. Right now in this country, AMH is an ELISA-based assay, as you all know. It takes us about 6 hours. But if we compare it to the automated platform that's currently available in Europe, outside the United States, and undergoing review by the FDA here, it's based on electrochemiluminescent assay. You can get the result in 18 minutes, so it's about 20 times as fast. Sensitivity is 10 times what it would be with the ELISA, and the precision's improved by 4 times. So sometime in the not too distant future, we may have access to this platform in this country, and it'll make it much more accessible. As you are familiar, there are a variety of different manufacturers of the ELISA. Probably the 2 main ones are Beckman Coulter and Anish, and these are based on ELISAs. The range on the Anish lab is much more sensitive, picks up values south of 160 picograms per milliliter. The significance of that is in the context of predicting menopause. The automated platforms, there's one by Roche, one by Beckman. The Roche assay is the one that's being reviewed by the FDA. And the one that I just compared all those, the ELISA versus the automated platforms, so that this allows us to have resolution with regard to non-responders, poor responders, normal responders, and excessive responders in the context of ovarian hyperstimulation, and affects the thresholds that we'll use to determine what medications we might employ. AMH and AFC, both good predictors of OHSS, so that this allows us to increase the safety profile of what we do. In terms of age-specific values, there's probably a dozen studies that have been done looking at how what we expect at certain age regarding AMH values, and over the course of time, with the peak being about 25 years, we have a age-appropriate decline, so that at some point, we may be able to use AMHs in the similar way that we use bone density, if you will, in terms of what your expectation is versus what you observe. So we know that as clinicians, depending upon a patient's age, their AMH, that helps us decide whether or not how much gonadotropins we're going to use, what type of GnRH analog we might use. And we're trying to maximize basically the sweet spot, if you will, of 8 to 12 oocytes, because we believe that much more than that, or if we have more than 12, it's not necessarily going to result in increased pregnancy. Less than 8, depending upon the population. So if we aim for about 10 eggs, if you will, that this will minimize the risk of cancellation and minimize the risk of ovarian hyperstimulation. We can individualize the protocols that we use, depending upon how. Whether you do this based on AMH or AFC, we can select what we think is the best clinical approach pharmacologically. And in terms of egg donation, we can make that a much safer endeavor by paying attention to a woman's AMH. If you consider doing split donors versus non-split donors, this is also useful with regard to helping us determine prior to stimulation who would be most appropriate for that. So the improved outcomes that we've seen, fewer cancellations, increased eggs, greater number of cryopreserved embryos. In terms of live birth rate, that's debatable. 2 meta-analyses have shown it has a weak correlation with that. That's no surprise, given that pregnancy depends on a lot of other things other than egg number. It's improved the safety profile, and in Europe they've shown improved cost efficiency. So after the age of 25, the number of follicles recruited to grow to mature antral follicles can be determined by AMH. Up until 25, not to be useful because it's still in a state of flux. As women of similar age display a wide range of responses, we use AMH to determine our strategic approach to optimize outcome. So in terms of cryopreservation prior to, or considering fertility preservation prior to cancer therapy, cancer treatment, the overall concept is that if someone has a good ovarian reserve to begin with, a high AMH, they're going to have this immediate decrease, but their recovery will be much faster and above the threshold for ovarian failure, if you will. So in terms of counseling patients, it's useful to know what someone's baseline is prior to undergoing therapy because it helps us understand what we might expect on the other side after treatment in terms of potential recovery. In terms of predicting menopause, we know age is a terrific predictor, and there have been a variety of different studies that have shown with increased precision, if you will. This is one particular study from Europe where the model was, and this as an example, at a given age, at say 40, the AMH is 1. They could predict the last menstrual period, if you will, between 50 and 52 and a half. Recently, this year, the SWAN study, which is the study of women's health across the nation, which is sponsored by NIH, and I apologize for the size of this abstract, but basically they looked at about over 1,500 women for over a 10-year period between the ages of 42 and 66. And using that low detection AMH ELISA kit, where the level of detection was down to 2 picograms per milliliter, they found that if the AMH were less than 10 within a 1-year period of time, 50% of the population would have their final last menstrual period, and within 2 years it was 75%. If the AMH value was over 25 picograms per milliliter, there was like a 97% chance that menopause would not occur within 2 years. So this is probably the most precise that we've been able to get, and this has significant promise. If for a minute we consider this in the context of PCOS, it's easy to understand how elevated levels of AMH inhibit FSH selection of the dominant follicle, so that we end up with what we expect to see in PCOS. But the other mechanism, sorry, I can't reverse this, is AMH inhibiting FSH's influence on aromatase, so that we end up bottlenecking the testosterone to estrogen conversion, and we end up with higher levels of androgens. So women with PCOS, we know, have a 2 to 3-fold higher level of AMH than healthy women, and that serum AMH levels have been reported to correlate with the PCOS phenotype with regard to hyperandrogenism, oligoanovulation, and PCOS morphology. In a meta-analysis, an AMH greater than 4.7, and many have rounded this off to 5, that this is consistent with a PCOS-like ovary, even if the other Rotterdam criteria aren't met. This study headed by Dr. Tal looked at elevated levels of AMH and broke them down into groups of 5. So if we looked at the 5 to 10 range, the 10 to 14 range, and greater than 15 range, as we increased the level of AMH, we saw an increase in the phenotypes of PCOS, so that testosterone, androgens increased as AMH increased, PCOS appearance on ultrasound increased, and the disturbance in menstrual regularity increased. So basically, the more severe the higher the AMH values, the more severe the PCOS phenotype. So that this may be changing the way that we look at PCOS. The group, all of these different influences may or may not interact with each other, some being more influential than others, and perhaps leading to a common final pathway having to do with angiogenic imbalance, which results in what we see in PCOS. So, the issue, one of the issues with AMH is that, well, what does a low value really mean? We know it has great correlation with eventual onset of menopause, but in the reproductive area, we know it's not predictive of, when it's really low, predictive of contraception. So in 2012, 2013, that was the first year that SART made it a mandatory requirement to report AMH if it was done. And so we looked at over 5,000 autologous cycles with the level of AMH being reported as non-detectable. So in the most commonly used assay was by Beckman during that period of time. And so those values less than 0.16 nanograms per milliliter or 160 picograms per milliliter. And as you would expect, the cancellation rate was much higher with a very low AMH. It was up 54%. A little more than 3% of cycles had no eggs. What was surprising was the fact that the live birth rate, despite a non-detectable AMH by that assay, was almost 10% per cycle start. So the bottom line is right now a low AMH, a very low, a non-detectable level, in and of itself isn't a reason to deny someone the possibility of treatment. When we looked at live birth, as you would expect, it was twice as high for age-matched individuals with detectable AMH. The multiple birth rate, as you would expect, would be much lower with those who had the ultra-low or non-detectable levels. And the cycles with embryo cryopreservation, a fraction of what it was for the age-appropriate matched present AMH values. So in the last couple of minutes, I just want to skip to... there's a variety of applications. We talked about the application in IVF, PCOS, pre- and post-cancer treatment, prediction of menopause. Family planning is probably perhaps potentially a very useful application of this. So if we take a 35-year-old with an AMH of less than 1, and she wants to have 2 children in the next 5 years, we compare it to a 35-year-old with an AMH of, let's say, 2.5. So the first woman seems to be more pressed for time if she's going to have 2 children within the next 5 years, just in general. And we wonder about the informed use of this in terms of reproductive planning outcomes to determine timing and spacing of having children, and the early evaluation and consideration of fertility preservation options, like egg freezing, so that we really, when someone comes in for an annual postpartum, their annual GYN visit, we spend generalists spend 98% of their time talking about birth control and contraception, and just making the argument that maybe we ought to have some idea of what someone's reproductive plan is over time. And the argument for discussion of family planning priorities. Multiple studies have shown that well-educated women's knowledge of age-related infertility is suboptimal. There's enough misperceptions about the timing and the rate of the decline of fertility with age due to overly optimistic expectations regarding healthy diet, technology, those things mitigating the natural decline in egg supply. And the fact that everyone in this audience is familiar with women just waiting to being later age of having their first child, that if there was some way to assess someone's ovarian reserve early on, that this might affect, we know that would affect people's decision about what they're doing. So this is a matter of debate. It's unproven at this point. It's something worth considering and has been argued in the literature, and obviously needs a lot further exploration. So, in terms of potential therapeutic pharmacological roles of AMH analogs, if we could develop agonists and antagonists, we can understand how it might be useful in retarding ovarian aging, delaying the onset of menopause, having a potential role in reversible contraception, chemopreservation for fertility preservation prior to cancer therapies, treatment of PCOS, potential treatment for endometriosis, adenomyosis, ovarian and endometrial cancer.